we will have 5 very interesting speakers today. Daniel Stewart, who is the dog behaviorist and dog handling expert from South Africa. He's having some technical problems, so we might have to leave him for the last. We'll have Dr. Ashwath Narayana from the Department of Community Medicine at Kempegowda Institute of Medical Sciences in Bangalore, India. We will have Mathilde Tetchi, the head of the Anti-Rabies Center at the Institut National d'Hygiène Publique in Abidjan, Côte d'Ivoire, also accompanied by Professor Kember from the same institute. We have Dr. Nasim Salahuddin, who you probably all know. She is with the Indus Hospital in Karachi, Pakistan, and a true advocate for rabies over many, many years. And we'll have Simba Mbaya from GAVI, who will be speaking to us about the upcoming GAVI investment. We will also have Dr. Ramesh Mashti, who will join us on the panel a little bit later, who also is from KIMS Bangalore. So with that, I will go ahead and start off with asking Dr. Ashwath Narayana to please take the floor and let us know your experiences about post-exposure prophylaxis, standard operating procedures, and the recently developed decision trees for better management of potential rabies bites. Thank you.
Thank you, Dr. Bernadette.
I would ask you to show your slides yourself.
Yeah, I will share my slides. I hope it is visible, madam.
Yes, very visible. Thank you. Please go ahead.
Okay. So thank you for this opportunity for me to make this presentation on rabies post-exposure delivery, a protocol and dysentery in this webinar conducted by United Against Rabies. This is mainly from the publication from our team in 2023, last year. And I'm going to make a brief presentation on the protocol, the decision tree, which are required for delivery of PEP in different countries. Normally, in majority of the situations, there will be the animal bite cases that comes to the health centers will be straightforward. Most of them will have dog bite or cat bite, and the decision is very, very easy, to, especially instituting the post-exposure prophylaxis or anti-rabies treatment in chart is very easy. But in some situations, where some special situations...
Narayana, I'm sorry for interrupting. Are you moving your slides? Because we only see the title slide.
Yeah.
Okay, now we can see. Thank you.
Yeah. So in some situations, special situations will be there, and there are some hospitals they rarely use or very rarely use this anti-rabies treatment or post-exposure prophylaxis. Their expertise may not be there. For them, this protocol and decision tree is required. So this is a step-by-step guidance on wound treatment, risk evaluation and assessment of the need for rabies biologicals, administration of RIG RMAPs, administration of rabies vaccines, and patient counseling. So there are totally 5 components in the effective delivery of PEP. So this wound treatment is very, very important because wound treatment in case of animal bite cases, it will reduce the rabies risk by almost 50%. So that's why it is very, very important that the patients as well as in the health centers, the animal bite victims, they do proper wound management. And then we have three important components in the decision tree. The first component is asking questions from the patient regarding the what kind of animal has been bitten and circumstances of bite and what is the animal, the status of the animal, all that. And then based upon that, we have to assess the wounds. So categorizing the wounds, and subsequently we have to institute post-exposure prophylaxis based upon the categories. So we have category 1, category 2, and category 3. So this is very, very important in delivery of a PEP. For example, in the first component, especially we are going to ask questions on the exposed person and also regarding the offending animal. So based upon this, we are going to decide whether PEP is indicated, not indicated, or to be discontinued, when to give PEP if they have taken PEP less than 3 months and they have got a re-exposure, there's no need for PEP. So this kind of a decision will be made based upon this history. And also delaying the PEP pending investigations and quarantine measures. So these are the questions are very, very, very important. Then next is evaluating the wounds. So the second part is whenever the patient comes to with animal bites in the health center, one need to categorize the animal bite wounds. Like category 1 is animal licks on intact skin, touching animals or feeding animals where there is no exposure or no risk of rabies. So we don't provide any PEP here. And category 2 are minor scratches or abrasions without bleeding and nibbling of uncovered skin. It constitute category 2, and they need only wound wash and vaccine. And the category 3, where in most of the health centers, or at least in our practice, more than 85% of the animal bite cases that comes to our clinic, they're all category 3, where there will be single or multiple transdermal bites or scratches, contamination of mucous membrane or broken skin with saliva, or contact with wild animals, including the bats. This constitutes a severe exposure where they require proper wound treatment, administration of rabies immunoglobulin or monoclonal antibodies, and complete course of anti-rabies vaccine by intradermal route. And then category in the third part, administering in the administration of rabies immunoglobulin or rabies monoclonal antibodies, it has to be done based upon the categories. So we have a practical guidance on how to administer immunoglobulin in all wounds and vaccine, which is especially the WHO recommended vaccine, the IPC regimen 222 two-site regimen to be completed within a week, which is dose, time, and cost sparing, is very much economical, and it has to be practiced across the world if you want to provide a complete PEP. And in summary, the effective delivery of PEP is very much required to make zero human rabies death by 2030. So with this, I thank you, madam, for a wonderful opportunity. Thank you.
Thank you, Ashwath, for a very clear and short presentation. I do thank you for keeping time. So I think one of the key messages here would be intradermal reduces your cost, your time, and is an efficient way of dealing with multiple patients and fractionating the dose and the importance of wound washing. I will now move on. Thank you very much. We'll have an opportunity to speak on the roundtable after the presentations are completed. We will now move on to Mathilde. Mathilde from Côte d'Ivoire. We would like you to take the floor. You have prepared a presentation for us. Please try to keep to time. I know your presentation is rather long, but we'll concentrate around how WHO recommendations were taken up in Côte d'Ivoire and how you were, as the rabies community in Côte d'Ivoire, were able to activate the national advisory group on immunization. Over to you, Mathilde.
Thank you, Bernadette. Good morning, everybody. Everybody hear me?
Yes, yes, loud and clear.
Okay, thank you.
You want to share your screen, Mathilde?
Okay, I will do it.
You can put on presenter mode. It would be good, Mathilde, please. Thank you. We can see it.
Okay. Thank you for this opportunity that you give us to participate to this meeting, Bernadette. So I'm going to present the process used by Côte d'Ivoire to introduce IDPEP. Rabies is endemic in Côte d'Ivoire. Management of patients was based on WHO intramuscular protocols, SN and Zagreb. For a better control, Côte d'Ivoire has developed a rabies elimination plan since 2018. And the initiative to introduce IDPEP has been in process in 2020. The first step of this process was to obtain the approval of the Vaccination Expert Committee and also the Ministry of Health. After this step, we organized a feasibility case study based on IDPEP in 2 departments of Côte d'Ivoire. As you can see, here we have the document from Vaccination Expert Committee and from the Ministry of Health. Our team carried out a feasibility case study based on IDPEP in 2 departments of Côte d'Ivoire. This study began with a local communication campaign on rabies in order to raise awareness among community leaders and local authorities. Theoretical training of the 2 rabies vaccination centers workers were carried out on correct use of ID route. The practical learning has been done for 2 weeks in a vaccination center that only uses ID route. In this study, IDPEP using requires patient consent first. And then we start by gathering information from patients before doing vaccination. As you can see, this photo shows how to administer rabies vaccine correctly by ID route. Before leaving the vaccination center, each person receives vaccination card for future visits, and we give advice to encourage them to respect the protocol until the term. We also call patients who have missed their visits. Based on this study, Côte d'Ivoire decided to introduce IDPEP in all rabies vaccination centers. So in 2023, theoretical training of all rabies vaccination centers workers was carried out for ID route using. And the practical training began on May 2024, now, for 1 month. At the central level, a committee has been set up to monitor the IDPEP introduced process. It consists to prepare documents for vaccine supply from GAVI, to obtain insulin syringes, to organize webinars with all managers of rabies vaccination centers each month. In conclusion, we can say that rabies elimination is a big challenge for Côte d'Ivoire, but IDPEP adoption could be an alternative solution. GAVI's rabies vaccine funding initiative is an opportunity to boost Côte d'Ivoire's healthcare system. So we believe that Côte d'Ivoire is ready to apply IDPEP protocol in all rabies vaccination centers before January 2025. Here we thank all our partners who support us, to particular WHO, who has helped us for the training of rabies vaccination centers workers. So thank you for your attention.
Thank you, Mathilde, for a very clear presentation, and also for your proactive work in Côte d'Ivoire on really aligning your policy to WHO's position and being one of the first to raise their hand to the opportunity for the GAVI investment, which you will hear more about from Simba in one of our last presentations. I know that one of the next speakers, Nasim, is having problems to join. So I will now ask Daniel to please come online and give us some of your experience around dog bite prevention and as part of rabies prevention.
Thank you, Bernadette, and it's great to be here, and welcome to everybody. As you say, is that, you know, when you're looking at rabies prevention, the idea is to actually stop dogs biting people. So it's a very big part of rabies elimination. But dog bite prevention is just a small but very important element in reducing mortalities from rabies, and has not been taken seriously enough in most countries that I've worked in my opinion. So when we look at rabies control in generally, we look at the dog being at fault. But we could also look at ourselves and see how we could improve our knowledge as well as our behavior. So if we start understanding dog body language to prevent a bite, I've categorized it in two different formats here, and I could speak on the subject all day long. So I'm going to try and keep it really short. If you're looking at aggressive, you normally see stiffness, white eyes, stiff body, exaggerated tail. Either it's really tucked or erect. There's a lot of vocalization, growling, snarling, that kind of stuff. The dog often stands its ground or approaching you in a threatening manner. It's normally also got a closed mouth. Now, on the other side, when the dog is feeling fearful, it avoids eye contact. It's got a shrunken body. It's hiding in a corner or trying to get away. It's got a low voice or an erratic voice. But we need to be very careful of both these situations. We mustn't allow a dog to approach you with a bad attitude. And we must not approach a dog that is showing fear. And I find a lot of times that's when people actually get bitten because they feel sorry for the dog. But how should we respond to a dog attack or a bite? First of all, people try and run. Dogs can run a lot faster than we can. So do not run. Do not scream. Try and keep as calm and as quiet as possible. Give the offending dog something else to bite, maybe like your handbag or your backpack or something else. Back away from the dog. Do not turn your back on the dog and try and run away. Face the dog, walk backwards. Be careful, of course, you don't slip. Try and stay on your feet. Sounds silly, but if the dog does push you over and you do trip and the dog does pull you over to the ground, roll up in a very tight ball and again, keep quiet. And now this is going to be very difficult. You might think the dog's disappeared, but wait for the dog to disappear totally and to leave you in your vicinity before you actually start moving. So now, unfortunately, let's say you get bitten. And if anyone does get bitten, it doesn't matter how small or large the wound actually is, we need to wash the wound with clean, flowing water. You can use soap, but it has to be flowing. A lot of people come along and put their hand into a bucket of water. Let the water flow. Wash that wound really properly for as long as you possibly can. And the WHO always recommends 15 minutes. So flush it properly, even allowing the wound to bleed if it's not life-threatening. Then go to your closest human health facility for further treatment and take the human health professional's advice and get vaccinated against rabies. It sounds silly, that comment, but unfortunately, I've come across so many people in the world that go, I don't want to get vaccinated because I got sick the last time. Please get yourself vaccinated and make sure you finish the recommended course of vaccinations. Oops. But in conclusion, a dog bite prevention education program should be implemented into all countries at school level. And this should teach compassion, behavior, simple first aid, as well as why would a dog want to bite you? So we can maybe just change our behavior. By being educated, we would reduce hospital care and treatments and create a better understanding of dogs. And then in the bigger scheme of things, having a healthier and safer communities. Thank you. And I hope I've kept it short enough for you, Bernadette.
Thank you very much, Daniel. Always a pleasure to hear and to know that actually we can prevent dog bites. Dog bites will never go away, but we can also prevent rabid dog bites. And that's always very encouraging and I think good to know and put into practice. We can start at home as individuals as well on trying to propagate this type of knowledge around behaviors around animals. And now we go to our next speaker, Dr. Naseem Salahuddin from Pakistan, who has been a wonderful resource for the World Health Organization and for on rabies in general, and as in the larger rabies community. Sometimes we are not able to stop the infection of rabies, and when signs appear, then the outcome is death. So we have asked Naseem to help us a little bit on what can be done when patients come to a hospital and are already showing signs of rabies. Over to you, Naseem. Please unmute. Please unmute.
Thank you, Bernadette. So as a clinician in infectious diseases, over decades, I have come across patients who land in the emergency room in dire conditions like cerebral malaria, severe sepsis, meningitis, even tetanus. And no matter what their condition, I've always been able to offer the family some help, to give them some consolation that even though this is a severe case, but we will be able to help out. And many times patients survive and sometimes they don't, depends upon the condition. But when it comes to a child or an adult with rabies, full-blown symptoms of rabies, I cannot give them false hope. This is 100% fatal disease once the symptoms have appeared. You know, of course, you can prevent at the initial time, but now it's too late. And the way I approach is to talk to the family, take them into a quiet room and speak in low voice, tell them, unfortunately, this is not a disease where your patient can survive, and not here, not with us, not anywhere else in the world, because there is no treatment. You know, the few anecdotal survivors are really not generalizable. So you talk to them in compassion, with empathy, and offer that they be admitted to the hospital. And if they do agree to get admitted, then we put them in a quiet room, in a quiet corner, if you have one. Start an intravenous fluid line because they're terribly dehydrated, and sedate them as well as you can using benzodiazepines. Sometimes you even have to use general anesthetics and give them some support with oxygen. But under no circumstances have I or would I ever recommend anybody to do CPR or intubate these patients, because that will just prolong life by a few hours, by a day or two, but ultimately the disease is fatal. And moreover, by intubating them, you're only going to spread the disease because the saliva might, go up in the air. Somebody might inhale, saliva land. There are ways that this could contaminate the surroundings. So absolutely not. So before, of course, we assess the patient that this is not something else other than rabies? Is it not cerebral malaria? It's not tetanus? There's sometimes overlapping symptoms, but once you're sure what it is, then this is the way to go. Then you just let the disease, the pathology of the disease take over until they pass away. And unfortunately, this has happened in my emergency room day in and not every day, but as frequently as I've seen rabies, they all die within 24 to 48 hours at the most. So that's really how unfortunate it is. You can't do anything more.
Thank you. Thank you, Naseem, and for your very practical and compassionate way of attending to this very delicate subject. And I hope that the countries will also be able to prepare some type of SOPs to support the clinicians and nurses in such situations to be able to manage their patients well, or if they go back to the village, to be able to advise how to best manage at a home level. So now I'd like to give the floor to Simba, my colleague from GAVI, to please provide us with the information about GAVI's investment in rabies vaccines and what the upcoming news is. Over to you.
Thank you very much, Bernadette, and hello to everyone.
Hi, Simba, you want to put it into presentation mode? Yeah, that's great. Thank you.
Thanks very much, Bernadette, and hello to everyone. So I'm going to try in 5 or less minutes to give an overview of the support that GAVI is going to be providing to GAVI eligible countries for strengthening their rabies post-exposure prophylaxis vaccination programs. If I am too fast for the interpretation, please let me know. So the GAVI board approved support for a rabies post-exposure prophylaxis vaccination in 2018, which was supposed to be implemented from 2021. But this was delayed because of the COVID-19 pandemic. And there was a decision to restart the design of this program in June 2023, and we're doing this, and we'll be launching the program next month. So the support that we are going to provide to countries is incremental support, incremental in the sense that we acknowledge that almost all countries already have a rabies vaccination program, of course, of mostly very small scale, and our investment is going to be on top of what the countries are going to have been providing as a way of strengthening their programs. So the support we are going to provide includes procurement of the actual vaccine doses, as well as associated supplies. So we are talking about the syringes and needles that are needed for the delivery of the vaccine. The GAVI program does not support vaccines for pre-exposure prophylaxis. However, in our guideline, which we are going to be publishing next month, we put a provision for opportunistic prep, where if a vial is opened for post-exposure prophylaxis, and there is a vaccine that is unused and is going to be discarded anyway after the 6 to 8 hours, and this vaccine can be used maybe to vaccinate veterinary workers or other animal handlers who are at increased risk. But this is just for that kind of when that kind of opportunity arises. But we do not have like systematic support for pre-exposure prophylaxis. We also do not have support in the current program for the rabies immunoglobulin. We are going to provide countries with the vaccine introduction grants, which is just financial support, so cash, to facilitate some of the activities that are needed for the vaccine introduction. So if the country needs funding maybe to train the healthcare workers to be able to do intradermal vaccination, if they want to print vaccination cards, if you want to do maybe some demand creation activities, so they can use these vaccine introduction grants. These are actually limited in amount, so there's need for good prioritization. GAVI also has other funding streams. For example, we've got health system strengthening grants, which are available to all the countries that are GAVI eligible. And so we also have targeted country assistance for all the countries, as well as the Equity Accelerator Fund, which is a fund for reaching children with 0 doses of vaccination. So countries can also, looking at their whole portfolio, their whole menu of GAVI support, they can see what is available from all those other funding streams that can help them to strengthen the delivery of their rabies vaccines. Of course, considering all the other priorities that are also supposed to be covered by those specific funding streams. So for a country application to be successful at the Independent Review Committee, which is the committee that looks at the applications and make recommendations on whether to fund the application, there are some things that we would want to see in the applications. So I'm just going to highlight a few things. This is not a comprehensive list, but the comprehensive list will be published in the vaccine funding guidelines, which is going to be published on the 12th of June. So we would ask the countries to have some evidence that a decision has been made in the country to request this support from GAVI. So we want countries to have the applications to have a signature of the Minister of Health or a designated authority. We want minutes of the NITAG or ICC or any other policy body in the country that made the policy recommendation to the Minister of Health. We also acknowledge that the rabies vaccine is quite different from all the other vaccines that we have been supporting. And because it covers different age groups, there is no defined cohort like a birth cohort, which we use for the other vaccinations, and it is post-exposure. So there are a bit of challenge there with regards to defining country targets and dose estimations. So we will try to see how best we can support each other to be able to make estimations, knowing very well that the initial estimations might be a bit off, but this will be refined as we have more and more historical data to base our estimations on. So as we've read that the WHO recommends vaccine delivery both by IM and ID, but we know from modeling work that ID uses less vaccines, there's less visits for the patients, and even in those sites where there's which are low volume sites, there's still some cost saving that comes from using intradermal vaccination. So we will encourage countries to transition from intramuscular to intradermal vaccination, and they can use their vaccine introduction grants for the required training. We also ask countries to think about comprehensive integration with the primary health care. We want countries to strengthen their surveillance, because we know that in most countries, rabies data is not available. We ask countries also to describe comprehensively their current vaccination program, including how much they are investing in the program, because the GAVI model is based on sustainability, and one of the biggest principles there is that we should not displace what the country has been investing as domestic funding. So we ask the countries to indicate in the application how much they've been investing as domestic funding, and we are going to provide additional support in terms of that. And we also need countries to think about equity in terms of ensuring that the vaccine is accessible to all people, all geographic locations, all genders, and this needs to be addressed. There's a question on comprehensive rabies control, which we think that is a very important part of the country applications, that countries need to think about vaccination of dogs. They need to think about strengthening IPCM, because we know that the GAVI investment is going to be most effective if we have all these complementary rabies control activities coming together. However, we understand that most countries do not have plans at the moment. Some plans are available in draft form. So we ask countries when they come with their initial application, we will not require them to have a comprehensive plan. But when they come for their next multi-year request, they will need to have a comprehensive plan in place. And there are some partners who are providing support in different forms to help countries to develop these applications, particularly through the UAR forum. So as next steps for the program, as I said, the program will be launched on the 12th of June. And countries will have the first opportunity to apply by the 15th of July. Then again this year by the 23rd of July. In subsequent years, there will be 3 opportunities to apply, and countries can take advantage of those. So we are going to provide TA in the form of consultants to help countries to develop their applications. And for those countries that are interested in applying through the first window, we realized that between the 12th of June and the 15th of July, there's just about 4 weeks, which might be inadequate to develop a good quality application. So we are already working with those countries that are interested now so that we can support the development of the application even before the launch of the program. Any countries that are interested can reach out to us through their respective GAVI senior country managers. Thank you, and over to you, Bernadette.
Thank you, Simba. Very clear, and we're all very excited that this opportunity is finally coming to fruition. So I think you've heard from Simba that countries can reach out either directly to GAVI and also to WHO for support in putting these applications together. Simba, a question to you before you close off. Many countries will ask, GAVI is providing human rabies vaccine. What about dog rabies vaccine? Are you providing that too?
No, so the GAVI program at the moment is just for human vaccination, but I know that there are some partners also who are supporting dog vaccination. I think WAR is supporting that, and maybe they can provide additional information. I see they are on the call. Thanks.
Thank you. Thank you very much, Simba. So we will now move on to the second part of the program, and this is to have a question and answer session with our panelists. We are trying to also answer your questions on the question and answer chat, should you have any. So I'll go to you, Dr. Ashwath and Dr. Ramesh. You see many cases, people coming with bites from potentially rabid dogs. What is your impression about how patients actually comply with vaccination schedules? And, do they come back? Do they have trust in the system? And how do you deal with people seeking care, for example, with traditional remedies?
Thank you. What we have observed is generally there's a delay in coming to the treatment. So if we can ensure that these people come on time, and the delay that is happening when they actually seek the first treatment, if that delay can be reduced, then I think we should be able to manage the case better. Second is there's a lot of myths and misconceptions which the people have, and many of them continue to follow the traditional treatment. So if the clinicians can be told about the clear message that they need to give to the patients about the importance of vaccination and rabies immunoglobulin at the earliest, then that's the next thing that we can do to prevent and control the disease. So what we have observed is with this background, coming to the compliance, if the clinician gives the very strong message and tells them about the seriousness of the disease, people do comply. Otherwise, they generally take it lightly, and by the third dose, they generally are not in a mood to continue with it, especially the day 14 and the day 28. Generally, they just don't come back. So I think it's very important that the clinicians send this message across that just not starting the vaccination, but also completing the course is very important.
So I'm also thinking that probably these shortened WHO schedules would be beneficial for compliance as well in countries where the policy has been updated.
Yes, very true.
Thank you. Dr. Ashwath, how important is wound washing in your experience as part of post-exposure prophylaxis?
Yeah, of late, with the increasing awareness and literacy level, at least in our country, people, they're doing the first aid at home. A majority do first aid at home and then come to the hospital. But very rarely from a rural background, people may not wash the wound, but they may apply the some plant saps and other irritants on the wound and then come. But this practice is coming down now with the increased awareness among the public, where the government and we are NGO, we are creating awareness. So it is coming down. Definitely the wrong practice is coming down, and good practices is being improved upon. Thank you. Madam muted.
You're muted, madam.
Yeah, thank you. So Dr. Mathilde will come to you next. You have talked about Côte d'Ivoire changing its policy to intradermal vaccination. Do you think it will be difficult to change the way healthcare providers provide care to bite patients, or do you think it is a feasible change?
Thank you, Bernadette. Can I speak in French?
Ouh, ok, c'est moi qui dois traduire. Ok, je vais essayer. Oui, allez-y.
Si je comprends bien, la question c'est est-ce que c'est facile pour nous de gérer les personnes exposées à travers le protocole intradermique?
Oui, est-ce que ça va être assez facile, fiable de changer les habitudes de gens qui travaillent dans le système santé?
Oui, il y a pas de problème. Il n'y a pas de problème puisque nous avons déjà mené une étude sur l'intradermique, une étude de faisabilité, et ça nous a donné une idée de comment gérer les personnes exposées à partir de ce protocole. Et même les agents de santé ont été formés à cet effet. Voilà. Et en dehors du projet, comme je l'ai dit dans la présentation, le niveau central a organisé aussi la formation de tous les centres antirabiques à l'administration de ce protocole. Voilà. Donc, pour nous, c'est vraiment aisé. En plus, nous avons un comité qui fait le suivi de toutes ces démarches, qui fait le suivi de la formation de ces acteurs sur le terrain. Et régulièrement, nous sommes en communication avec ces acteurs, les responsables des centres de vaccination, qui nous font des retours sur le stage pratique qui a commencé depuis le début du mois de mai, qui va prendre fin certainement en fin mai, où nous allons conclure pour pouvoir maintenant lancer la mise en œuvre de façon pratique.
Merci beaucoup. So Mathilde has said for now they have conducted a feasibility study in 2 districts, and it has shown to be feasible. Then all the health workers in all centers for rabies centers have now been trained, and they will be kicking off the program after a review at the end of May. Have you seen any big problems in the rollout of intradermal? Est-ce qu'il y a de grands problèmes que vous avez rencontrés? Non.
Non, pas véritablement. En tout cas, tout s'est bien passé. Il n'y a pas de problème majeur dans le déroulement de cette procédure. Voilà, tout s'est bien passé parce que antérieurement, nous avons commencé par un projet GAVI où nous avons fait le Thai Red Cross d'abord, et puis après ça, nous sommes passés avec ce récent protocole intradermique. Donc, franchement, tout se passe bien. Nous avons de bons résultats sur le terrain. Et vraiment, je répète encore, on voudrait dire merci à l'OMS pays, en Côte d'Ivoire, qui nous a soutenus dans la formation pratique et même la formation théorique a déjà eu lieu et nous sommes soutenus et nous sommes lancés encore pour la formation pratique.
Merci Mathilde, merci beaucoup. So in very summarized form, they have not encountered any big problems in the change from intramuscular to intradermal vaccination in Côte d'Ivoire. They already had been testing out the thyroid cross, which is a longer schedule, but now are really moving to the shortened schedule in Côte d'Ivoire, prompted also by the fact that GAVI is rolling out and is interested, and Côte d'Ivoire is interested in drawing on the support from GAVI. And so I would like to ask Professor Thiembre,
Okay.
you have your hand up. Would you like to switch on your video and add anything to Mathilde's contribution?
Oui, merci. Bonjour à tous. Je voudrais saluer tous les participants, remercier pour cette opportunité et puis souhaiter que la prochaine fois, on puisse tenir compte des francophones. Moi, je préfère m'exprimer en français parce que c'est ma langue de travail. Je pense que les questions qui ont été posées sont très pertinentes. Effectivement, nous avons essayé la vaccination intradermique dans deux localités, mais il y a quand même quelques difficultés. C'est vrai que dans l'ensemble, tout se passe bien, mais nous avons le problème de taux de perte qui était attendu. Et donc, parce qu'on a des centres où il y a souvent très peu de personnes qui viennent, donc ça, c'est un problème auquel nous allons nous pencher. Et puis, bien entendu, je reviens sur ce qui a été dit, la voie intradermique, c'est une voie particulière et donc nous suivons attentivement comment les agents vont appliquer cette méthode, cette voie intradermique pour être sûr que nous n'allons pas avoir un problème lié à l'utilisation de cette voie intradermique. Voilà, merci.
Merci beaucoup, Professor Thiembre. So just in a very summarized form, to us, the Secretariat of the United Against Rabies Forum, we have been encouraged to really have French interpretation the next time. I agree with you, Professor Thiembre. We will try to do our best. Professor Thiembre has reiterated what Mathilde just said, but has also just highlighted that, you know, they will keep a close eye on assessing the rollout of intradermal vaccination to make sure that there are no great problems and that they can solve problems efficiently on the way. Thank you very much, both of you from Côte d'Ivoire. We really are excited that you're going to be coming forward to apply for GAVI support. I would now like to call on Nassim. You mentioned that nothing can actually, not a lot can be done in treating rabies once it comes. The signs show up. What are, do you think, the reasons why sometimes you notice that children might be the most afflicted by rabies and are the ones that report late to your clinics?
Well, children will always be children. They may not have told their parents that they were bitten by a dog. They'll get, more upset about it. Grandmothers would threaten them that if you get bitten by a dog, you're going to get those 14 nasty injections into your belly, so they will not report to their parents. But nevertheless, children are more prone to it because, they can't run away from a dog that's going to attack them. They also provoke and tease dogs and can't run away fast enough. Or if they do run, they fall, and then the dog we've seen many instances where the dog has actually mauled the child in the back, in the arms, in the leg, and then, you know, then they're brought to the emergency room in that state. Well, we've seen that too. So, but if they're not treated properly at that time, if they have multiple wounds and you don't have the immune globulin, and you don't haven't washed the wounds adequately, why then you really can't hope to save them after, when they're brought in 2, 3, 4 weeks after the bite. So adults too, sometimes they think that the bite is not bad enough, that they should consult a physician. They may apply some local remedy, or they may even wash it, because we've done a lot of awareness programs and we keep shouting from the rooftops that if you ever get bitten by any animal, please wash your wound with soap and water for 10, 15 minutes. And we are being heard, whether it's from the press or from you know, from one person to another. When they come to the emergency room, they bring in a family member, we instruct them, tell them very clearly that you just spread this message in your neighborhood. So we've seen a good number of people who come in with washed wounds. But children generally, if they don't report, then that happens, yes.
Thank you very much.
As a matter of fact, just last week, we had a case of rabies. And no matter how much we probed, the family said, no, this child was never bitten by a dog. So, you know, we couldn't argue, but obviously the child must not have reported. So this was just a case in point, only about less than a week ago. And of course, the child died. Yeah.
Thank you, Naseem. And I guess this gives us a full circle back to Daniel on bite prevention, but also your very strong messages about what Dr. Ashwath already mentioned and Dr. Ramesh about early health seeking, wound washing, so important. But let's go back to Daniel. Give us a couple of last messages around what is it that we can do in communities better in order that children have, first of all, confidence to tell their parents if they've been bitten or scratched by a dog that has been behaving oddly. And how do we prevent those type of things happening in the first place? Just a few closing remarks from your end.
So it's a good question, Bernadette, and I think it comes down, and I keep on saying this, and I keep on saying this to the world every time I have the opportunity. But you know, as Dr. Naseem said, children are affected. Everybody knows that, but we're still not educating them enough. And you know, if we can come along and just have a very short education, proper education system in their curriculum on when not to, what to do, simple first aid, I do believe that's going to make a world of difference to communities, to individuals, and we won't be able to, you know, hopefully we'll be reducing the trauma that Dr. Naseem's team has gone through this last week by seeing a child die in a hospital bed. And I find that a lot of times we find simple things that we could have prevented by, you know, a child will go and pick up a puppy, a young puppy. The mother's going to protect that puppy. Now, if we'd educated them, they would have left the puppy alone. A lot of times we find that dogs will be eating food and kids will go along and investigate the food. Just why? Just leave the dogs to do what they do. And then I find that from an adult bite point of view, people feel very sorry for dogs, and they see them on the side of the road, and they'll go along and try and pick up the dog to take it to shelter or to a vet. And there you actually have, you know, got bitten because you're caring. But if people actually know who the experts are, welfare or people like that, they can go out and you call them. But Bernadette, my bottom line is, let's create a true education system that can be implemented into every single school. And I'm telling you now, it's going to make a world of difference.
Thank you very much, Daniel. And we are taking those messages on board, even through the GAVI rollout. And in the discussion with UNICEF, we're also looking at seeing how we can prepare packages for countries to customize. And then, of course, it'll be up to the countries to roll this out through their education systems. There are a few questions in the chat, but I would like to come back to Simba around, you know, what do you think are the best? You've listened to all this discussion about rabies and what countries are experiencing or individuals. What would your message to our participants be today? Perhaps reiterate some of your key deadlines.
Thanks, Bernadette. So I think the main message is that for those countries that are GAVI eligible, the support will be available. First opportunity to apply is by the 15th of September, then by the 15th of July, then by the 23rd of September this year. We know that in countries, sometimes there are other multiple priorities, maybe other applications for other vaccines that GAVI supports that are already in the pipeline, and sometimes we don't have visibility of all that. So it would be great to liaise with the GAVI senior country manager for the specific country to express the interest, and then to find out also in discussion with EPA programs what else is being prioritized, so that we can make sure that the rabies vaccine is sequenced accordingly also to the other priorities that are coming up for the country. But the support is there, and we are ready to support countries to develop their applications and to implement this program. Thanks.
Thank you, Simba. And then just one last question for you. You know, I guess for rabies, data is a little bit patchy sometimes, but we do need rabies data. And can you give us one specific reason, and one of that we are struggling with at the moment, why we do need this data, especially as we're planning for this rollout?
Thanks, Bernadette. So we need data, the like number of dog bites, the number of dog bites that need vaccination, so that it can help us our budgeting, our forecasting, so that we know what number of vaccines that we should think about procuring for each of the years that are coming up. So it's really important that we have this data. At the moment, I know in most countries this data is really scarce, but I think as countries begin to roll out their programs, I think we need to improve our data systems so that we can use this historical data to improve our forecasting and our budgeting. Thanks.
Thanks so much, Simba. Very clear. And I think over the next few years, as countries come forward, this part will improve, and also we can measure what this investment has changed in health of people. So thank you very, very much for being with us. And I see Nasim has her hand up. I think it will be a question to you, Simba, so please stay on.
Yes, I was going to ask Simba, you know, accurate data is impossible to tell you how much how many dog bites, how much PEP is being used. So how are you going to figure out really project the number of doses or whatever you can provide? Is you know, in my country, in the province of Sindh, there were 200,000 dog bites reported in the first 10 months of 2023. I mean, that's enormous. So that's just one province, and then we have 4 other provinces. How are you going to project that? I'm curious.
So at the moment, we are trying to use modeling data to just try and estimate how many doses we should procure, I think, for the initial phase of the program. We also can ask countries to bring in the application whatever data they have from the country, maybe based on their previous procurements, or if they've got whatever data on dog vaccination which they have, and then we try to find a way of estimating the doses. I think it's clear that as we are starting the program, whatever data we are going to have from modeling or from whatever the countries have is not going to be very accurate. But I think as the countries, the programs are rolled out and they've got a better understanding of their needs year after year, I think in a few years' time, then we'll be able to make a more accurate forecast. But for now, we understand that it's really going to be quite variable between countries, and it's a risk that we know and that we accept. Thanks.
Thank you very much, Simba. And thanks, Naseem, for that question. I'll turn back to Dr. Ashwath and Ramesh for Naseem explained to us about palliative care, final care of patients dying of rabies and the support. Perhaps you can give us your perspective from your own clinical experiences around what can you support families with? How do you support families as they accompany their family member to through rabies and death?
Yeah, we usually explain the prognosis to the patient attendants that it is the rabies, it is 100% fatal, he is going to lose, we are not able to save the life. So after explaining that, we have to make them understand. Usually first is denial, they'll be aggressive. They say the diagnosis is wrong, something like that. But subsequently, once we convince them, counsel them, then palliative care or supportive care, end of life care support. So we need to do that. And after that, in our country, we are able to admit these hydrophobia cases in the designated epidemic disease hospital or isolation hospitals, as government of India has made human rabies notifiable. So this is a turnaround, and now people have started admitting. So we are going to get some information about how many rabies cases, and we are not able to. This is the only support that we want to do it, because earlier they were turned away from the hospitals, saying that looking at the prognosis. But at least now we are admitting cases and providing the end of life care support. And making them have at least a painless death by giving this palliative care in our hospitals. Thank you.
Thank you very much, Dr. Ashwath and Dr. Ramesh. And perhaps would you then advise countries to have a standard operating procedure should they encounter rabies cases?
Yes.
Thank you very much. Another question that came up, and it might be to Naseem or even to Mathilde, and perhaps even to Ashwath and Ramesh. What if immunoglobulins are in short supply, but there is vaccine? What can we actually recommend if we have very limited amount of RIG? And I see Naseem, you're ready to speak.
Yes, in many places, RIG is just not available at all. So many places keep on referring from one institution to another where they know that RIG is available. And fortunately, at Indus Hospital where I work, we have as yet not run out of supply of RIG. So, but in other places, what we recommend is that you give them the 4-site intradermal. Number one, you prioritize patients who should definitely be given RIG, like in the head and neck and face, highly innervated areas like the fingers. So that's what, and of course, most important we emphasize is wash the wound. You know, that might reduce the chances of rabies by even 1/3. That's what it says in literature. So if you wash out the saliva and reduce the burden of the virus, it might be of some value. But if there's not, then we keep receiving patients from other institutions, from other parts of the country or other parts of the province, because they know they don't have RIG and they must have it. So they send them over to our hospital. So that's really the best they do. Yeah.
And do you scrub the wound?
Oh, yes.
I mean, people use brushes. That seems not to be recommended. Do you wash it, but not with any violent sort of?
Oh, yes. No, because these are painful and deep wounds. Sometimes you can't use a brush. At best, we might use a sponge, a soft sponge, but scrub it. Yes, this is what we
Scrub it, but not with any wound inflicting type of
right. Just soap and water, and then apply an antiseptic. That's the best. Yeah.
Thank you. Mathilde, you might have some recommendations around when rig is in short supply. One of the things perhaps, Naseem, that we missed is WHO does no longer recommend any leftover immunoglobulins to be injected into the muscle, right? It's only into the wound. So that's one way of saving some of the immunoglobulins.
That's right. Yes.
Thank you. I would like to speak in French.
Okay, go ahead.
OK. Donc, je dis que en Côte d'Ivoire, les immunoglobulines ne sont pas disponibles à l'intérieur du pays. C'est disponible seulement à Abidjan, au niveau de la capitale. Mais bien sûr, au niveau d'Abidjan, nous recommandons les immunoglobulines. Nous commençons d'abord par dire à la personne exposée. Donc, nous faisons le lavage de la plaie à l'eau au savon pendant 15 minutes. Mais nous conseillons aussi, nous sensibilisons la personne exposée pour pouvoir accepter l'infiltration de l'immunoglobuline au niveau de la plaie. Mais il faut dire qu'à cause de la rareté de ce produit, le coût est très élevé. Le coût est très élevé, donc rares sont ceux qui acceptent d'acheter l'immunoglobuline. Et donc, quand c'est fait, nous faisons l'infiltration. Mais il faut dire que c'est un produit qui n'est vraiment pas disponible à l'intérieur. Donc, les centres anti-rabies que nous avons à l'intérieur de la Côte d'Ivoire n'ont pas la possibilité de faire l'infiltration du sérum. Donc, l'une de nos recommandations ici, c'est de demander à l'OMS certainement de nous appuyer, voilà, de nous appuyer dans l'acquisition des immunoglobulines. Merci beaucoup, Bernadette.
Merci, Mathilde. So in summary, Mathilde says that immunoglobulin in Côte d'Ivoire is only available in the capital city, Abidjan. So their standard operating procedure is wound washing and vaccine, but the rig is at the cost of the patient, and it is at a very high cost. So often, even if the immunoglobulins are available, it is not actually accepted by the patient. But we have looked at the literature in quite a bit of depth, and as it suggests to say that if we can get, especially in the not, the very severe bites in the head and neck, and then perhaps in the hands, are really do need immunoglobulins, but often our patients do survive even just with vaccine if it is given immediately after the dog bite, as soon as possible, and the wound is washed sufficiently long enough. So that is already life-saving. And the GAVI will request countries. Simba, you might have more information around this. GAVI will request countries to explain what they are doing with regards to immunoglobulins, right?
Yes, absolutely, Bernadette. So we appreciate the importance of immunoglobulins, but at the moment the GAVI program does not have support for that. But we will ask countries just to describe in the application what is the status of access to immunoglobulins and whatever they are doing to try and improve access to immunoglobulins. Thanks.
Thank you very much, Simba. If we have no other questions, there's a Daniel, you'd like to take the floor before we close. Daniel, please go ahead.
There we go.
Yeah, okay,
I'm on. Sorry. One thing that came across, and we haven't really discussed this at the moment, is if the dog does bite us, and we know who the owner is, and we can maybe even quarantine the dog, is it still advisable to quarantine the dog? In my opinion, it is, but we must always look at the welfare implications of quarantine a dog. And after a quarantine period of 10 to 14 days, how do we, or do we still continue treating the patient for the other remaining doses if the dog is still alive and showing no symptoms? I'm seeing this quite often, that this issue comes up. My concern is, of course, a welfare implication of a normal dog, healthy dog, being tethered incorrectly. But at the same time, is that even if the dog is tethered and is fine, a lot of the health clinics are still continuing with the treatment and using the vaccine, that we now prove that we don't need to do the vaccine, because when the dog bit, it wasn't shedding the virus. So it's a very open-ended question or comment, but I think we need to start looking at it to work together from whoever's placed the animal in quarantine and the health facilities to speak together about that follow-up of those biting dogs.
Thank you, Daniel. And we have already touched a bit on these around integrated bite case management. And I think many countries are starting to roll out bite case management in that when a person reports to a clinic, there is an investigation that goes on in the community. It's not always feasible. Bite case management needs also good surveillance. So it is something we'll be working on in some of the upcoming series. But I would also invite our guests to go to our open WHO training course that has a module around integrated bite case management. Thanks a lot, Daniel, for bringing that up.
Thank you, Bernadette.
So as we come to the end of our webinar today, I thank you for your attention and your attentive presence on this webinar. We've had many participants. I would like to also announce that there will be more webinars. The dates are usually posted on the United Against Rabies website. Please go there to follow any upcoming webinar dates. We also will have the resources available for you to download on our United Against Rabies website, and other resources that you might find interesting, including what Daniel just recently brought up about bite case management, integrated bite case management. I would also like to point to WHO's new resource with the support of Kim's in Bangalore on the decision tree to support our clinicians in making a good decision around how to manage their bite patients best. It helps make a risk assessment for the patients coming in. If you have any questions to us, or we haven't answered some of your questions, do reach out to us. Our email address is globalrabiescoordinator@woah.org, and please do reach out to us should you have any other things you'd like to discuss with us. With that, I'd like to thank all our speakers who have done a wonderful job today. This is truly very good to know that you are there to support the larger community in reaching 0 by 30 rabies by 2030. I would also like to thank Deborah Nadal, who has helped put this webinar together, and our secretariat for organizing this webinar for us. So with that, I thank you all. I wish you all a great day, and I also wish you all the best in your program so that we do make the end of rabies a reality. We have to. It is our ethical responsibility, and we need to really use the opportunities we have, for example, that of GAVI, to make that progress happen. Thank you very much.
Thank you.
Thank you. Thanks a lot.
Yeah.
Merci et à très bientôt.
Merci beaucoup, Professor Chairman.
Oui, merci.